Really excited to be talking about this topic, which is really near and dear to my heart. All right, so no disclosures. And I just want to start by saying, my exposure to obstetric fistula started way back in 2007 when I spent a year working at the Hamlin Fistula Center. At that time, I was just a fresh graduate from an OBGYN residency program at Washington University. And I had decided that this was an area that I wanted to focus on, especially with women's pelvic floor health. How do we support women after childbirth injuries, which is a huge problem in Ethiopia, as well as a lot of countries in sub-Saharan Africa. Having grown up in Ethiopia, this was really an area of interest for me. And in my stay at the Hamlin Fistula Center, I have to say, as many people will tell you who have been in that institution, it was a transformational experience. Not only just learning the stories of these women who had to go through this incredible ordeal of childbirth and childbirth trauma from preventable cause, but also understanding some of the social, cultural, political reasons for why they are in the place that they are, what it took to take care of them. If you've had the privilege of visiting the obstetric fistula hospital at Hamlin in Addis and other centers around the country, you will see that it really takes a village to care for these women. One of the fascinating things there was also how prior fistula patients turn into nurse assistants and provide the most compassionate and dignified care for this woman, which is what they need, because the trauma that they experience extends far beyond the physical trauma, and I'll talk a little bit about that. So it was a really transformational experience for me. The other thing I really appreciated from being there was that we had OBGYN residents from Addis Ababa University, St. Paul coming and rotating with us. And I got to know a lot of the most amazing obstetric gynecologists who, went on to lead country's OBGYN efforts later on. But they taught me a lot because we had a lot of time to sit and talk about the healthcare system, the educational system, what is working, what's not working. And these were all really the beginning of my interest in this area. So I want to give a huge gratitude to what the Hamlin Center is doing, and to Dr. Catherine Hamlin and her husband, who I never met, for being there doing the work that they do for the community. So, I put this picture here too to show you my son was, at that time 2 years old, and just recently graduated from high school and went to college. So that was it always gives me a good timeline of how much time has gone by since my first kind of introduction to this issue. So what is obstetric fistula? I don't want to assume that the audience here, everyone knows what it is. So I'm going to very briefly describe what it is. Obstetric fistula is a childbirth injury, a preventable childbirth injury that happens when a women are in labor and are unable to deliver their baby vaginally for many reasons. It could be because the pelvis is too small. As you know, a lot of, especially in rural communities, a lot of girls get married early. This is one of the big risk factors. And they haven't even finished growing completely yet before they become pregnant. And so sometimes the pelvis is just not adequate to allow the baby to come out. This could happen even in grown-up women. Our pelvises are very different from woman to woman, and some women have wide pelvises and some women have very narrow pelvises. And The women who have narrow pelvises cannot have babies vaginally for that reason. And that's why we have this thing called C-section. Sometimes the baby comes the wrong way, and that may be the reason for it. Unless you diagnose that ahead of time with ultrasound, saying, okay, which way is the baby coming? And, advise the woman, for example, if the baby's coming in a transverse position, she's not going to be able to have a vaginal delivery. She will need a C-section. This is why you need good prenatal care, good peripartum care to be able to diagnose those things. And then another reason could be the baby is just too big. Sometimes some medical conditions like diabetes, if a woman has diabetes during pregnancy, the baby could be big and she may not be able to deliver the baby vaginally. You wouldn't know that if you did not have good prenatal care and diagnose the woman early. So for all of these reasons, if the baby's head gets compressed in the pelvis and causes ischemic injury to the bladder or the vagina, or both, especially in the setting where women are having labors at home and they're not able to empty their bladder, for example, and they could be extremely distended. That could then lead to injury of the bladder. It could happen between the bladder and the vagina at different levels. It could happen even higher up between the uterus and the vagina. It could happen between the rectum and the vagina. So you could get obstetric fistula either between the bladder and the vagina or between the rectum and the vagina. That could result in a continuous leakage of urine or stool or both. It's an incredibly debilitating condition. I think the saddest part about it is a lot of times these women don't actually know what happened, and they could blame themselves. They could be ostracized, and they may not actually get to care on a timely basis. They could end up being isolated, divorced, and all of those things. So it's not uncommon for women to live with these conditions for years sometimes before they get diagnosed and are treated. And I'll talk about other trauma that happens beyond the hole in the wall, as we would say. This is a bigger problem than just a hole in the bladder or on the rectum. So approximately 1 to 2 million women are thought to be affected annually by fistula. It's really difficult to get a really good prevalence number of fistula. Part of it is because we're not doing a good job of doing good surveys. Part of it is a lot of women affected by fistula are hiding and they may not feel comfortable talking about it. Part of it is that even when we are doing surveys, if you're just doing questionnaires or surveys, you could actually miss a lot of fistula because it could get confused with other conditions, such as just, leakage of urine that happens after childbirth, even without fistula. So without proper clinical assessment and confirmation, it would be really difficult to assess the prevalence. Most fistulas, almost all, are in sub-Saharan Africa and Southern Asian countries. And we think about 6,000 new cases a year. In Ethiopia, the prevalence rate that have been reported, again, was very suboptimal data gathering, is less than 1%, but it's still significant number of women that suffer, given what a large population there is in the country, and how much of that population lives in rural communities, which are at higher risk. So like I said, the trauma of fistula goes beyond the hole in the wall. It's like the only, honestly, similarities, the way I can describe it is when you have war and you have an explosion of some sort, the damage is not just on that one building that is hit by a bomb or a missile, right? A lot of the buildings in the surrounding area also are affected. And not to mention the psychological trauma of people who go through war. And this is very similar for fistula as well. Some have said obstructed labor complex to go beyond just the fistula. So this is in the middle a picture of a woman who actually I got to know when I was working there as she became a nurse assistant, and she did not look anything like this picture, but this is what she looked like when she came. She was restricting fluid and restricting food because she was leaking stool and urine constantly. No access to readily available cleaning, water, pads, things like that. So a lot of these women just sit in one place to avoid contaminating their surroundings. And that leads to emaciation, contractures of limbs, and even nerve injuries that cause foot drop. So sometimes when you see these patients come through, you actually have to do a lot of nutritional and psychological and physical therapy, resuscitation before you can actually operate on them, because otherwise your surgical outcome is going to be really poor. Fluid restriction can also lead to bladder stones, as you can see in that top picture, kidney stones, bladder stones. They could be injuries to the other urological organs like the ureters that might require ureteric reimplantation. Sometimes if the bladder is really injured and there's no normal tissue left, you actually need to do diversion surgery, all of which is done at the Hamlin Addis Ababa Hospital. There are risks of infertility from scarring of the vagina, and there's a huge mental health burden as well. So, like I said, the trauma extends far beyond the hole in the wall. So you can actually repair the fistula, and the woman can still have very persistent, ongoing chronic conditions, including ongoing incontinence through the urethra because of the damaged continence mechanisms as well. And of course, the mental health burden. We did a couple of studies, one in Uganda and one in Ethiopia at the Mekelle Hamlin Fistula Hospital. And we found out that 40% of the women who had successful fistula repairs continued to have a very severe persistent urinary incontinence, and that it has moderate to severe impact on their quality of life. We found that about up to 42% of these women, irrespective of whether they continue to have incontinence or not, have had suicidal ideation. And those with severe persistent incontinence are twice as likely to have made a plan to commit suicide, 6 times more likely to have attempted it. So again, even after successful fistula repair, the psychological burden because of the continued incontinence is huge. This is actually part of the incentive, this observation, as well as what I was seeing at the Fistula Hospital when I was there, was women continuing to have debilitating pelvic floor problems after fistula repair that led to some of the work we did with starting urogynecology fellowship programs in Ethiopia. This is a picture of our first 4 fellows who graduated from the program. We've now graduated 5 fellows, and we have 2 more that are graduating in early 2024. You probably recognize some of these people: Dr. Malaku, Dr. Fagada, Dr. Bito, Dr. Yeshina, all of whom are really leaders in fistula work and pelvic floor work, where we started a fellowship program between Hamlin and Mekelle University. This is a 3-year fellowship program that has been going on since 2015. And the idea behind this is, how do we care for this woman who continue to have debilitating pelvic floor conditions and other, heavy burden of other pelvic floor conditions such as prolapse and ongoing incontinence, even without fistula in the picture. There are huge numbers of women who have these conditions in Ethiopia who need specialized care. And I'm excited to see that there are now more efforts in different institutions to start and lead urogynecology training programs, and really excited to see some of our graduates helping with some of those efforts as well. So when you talk to this patient, so this is a patient I met outside of Bahardar at a health center when I was there, who had both vesicovaginal and rectovaginal fistula. She actually also had limb contractures and couldn't really walk much. So she was having a nutritional support, a mental health support, physical therapy to get her ready for fistula. I remember her mom asking me, is my daughter ever going to be able to walk again? And she was actually, this woman was leaking urine and stool, and her mom was concerned about her mobility as well. And it's heartbreaking to see. And I've heard many different variations of this story. I've heard stories of women who actually tried to go to the hospital on time, but couldn't because it was the rainy season and the river was full and no one can get them there, because transportation was difficult. I've heard women who actually made it to the health centers were watched for hours during labor. The health center couldn't do C-section, so they transferred them to referral hospitals. They waited there for another several hours, and then they get transferred to another level of care. And by the time they get there, it was too late. Part of the challenge is also access to emergency C-section services at our facilities. I have even heard stories from one of my patients who made it to the hospital where there was an OBGYN, but that OBGYN was the only OBGYN at that hospital and has been at the hospital nonstop for 3-4 days prior and had gone home to sleep and couldn't come in to deliver her when she was in this situation. And she actually ended up with a uterine rupture overnight and almost died. And a part of the challenge was the situation is not just that patients don't know to go to the hospital or to the centers, but that when they get there, they may not actually have access to the care that they need. So it's a huge challenge. I think the last data I saw from 2021 mini Ethiopian demographic survey shows only about 52% of women still deliver at home, which is a big problem. But I would say that even if we increase the number of women who are delivering at health facilities, if we're not set up to care for them in a dignified, compassionate, quality way, this will continue to be an issue. So the three real, main delays to care, one is reaching care. Like I said, sometimes transportation is a challenge. And as you know, the landscape in Ethiopia is not easy to navigate. This is kind of the rural ambulance that you see there, the little chair. Women are sometimes you need 15, 20 people to get the woman to a hospital because she needs to be carried on the shoulders of men to get there. Deciding to seek care in the first place is a big issue because women are not empowered to make their own healthcare decisions in a lot of ways. So they're not necessarily able to decide and say, I need to go to the doctor right now. They rely on the decisions of their husbands, their parents, in-laws, and other people, especially if they're married at a young age. And then there's the issue of actually receiving quality care. Like I say, this was a picture of a labor bed that I took a picture of this actually at that center where I met that patient that I described. You can see it's missing one of its stirrups. And the person who is running this center told me that women would rather die at home trying to deliver than come to our center because the center setup is so bad that they don't want to come. So again, if you don't have good healthcare facilities and people who know how to care for this women, it can be one of those barriers that keep women from coming. So, the topic of my talk is the end in sight. Here's the good news. The good news is that we know obstetric fistula, number one, is treatable. And we've seen how successfully this is done at the Hamlin centers. Ethiopia is very fortunate to have that center in many different locations. And some of these fistulas are also being done in government hospitals. They do a great job with holistic care. I think we need to extend that care to some of those chronic conditions after fistula by expanding urogynecologic access as well. But I also think that we need to make sure that a lot of that care is being provided at government institutions, that our healthcare professionals who graduate from obstetric and gynecology training are trained to be good and skilled fistula surgeons, instead of us entirely relying on non-governmental organizations and donations to take care of this problem, because that's not a very good sustainable model. This has to be incorporated in the way that it's in the government infrastructure, in the training infrastructure. The even better good news is that obstetric fistula is a preventable condition. How do we know that? We know that because we hardly ever see fistula from obstetric labor in high-income countries. And that's because they have improved access to obstetric care, access to safe C-section, to emergency obstetric care. And there's no reason why we cannot do that as well. And we've seen the impact of that in the West. As you can see, in the United States in the 1920s, the maternal mortality rate was 700, 800 per 100,000. And in the 1960s, with introduction of comprehensive access to obstetric care, they cut that down to less than 20. And there is no reason why we can't do that. Right now in Ethiopia, the number is around 400 per 100,000. We've made huge progress, but we have a long way to go. The other issue is lack of access to obstetricians, anesthesiologists. According to the Lancet Commission report, looking at these numbers, you can see in Ethiopia, the recommendation by the commission was about 20 surgical healthcare professionals per 100,000 population. In Ethiopia, it's less than one. It's one of the lowest in that region. So again, we have a very long way to go. I know we do a lot of task shifting as a result by having general practitioners and health officers do C-sections, for example. One of my concerns was that, although that's helping, is that we're now trying to train a lot of learners with very limited resources. That's compromising the quality of care. This is a picture I took at Meghalaya University during morning rounds in OBGYN, and you can see the number of learners couldn't even fit in the room that we're seeing the patients in. So a lot of these learners are not actually listening to what's happening at the bedside. This is even worse for surgical training. A lot of them are graduating with very minimal surgical skills, but then they are expected to do the surgeries when they go to the rural hospitals. This is actually the reason why we're seeing such increasing trends in iatrogenic fistulas. So as we're reducing the risk of obstetric fistula-caused fistulas, we're seeing more and more injuries to bladder ureters that are causing even more complex injuries on this woman. So we are kind of replacing one problem with another if we're not careful about the quality of training that we're providing to our healthcare professionals. So is there a way forward? I want to end just by saying three things. I can give you a list of things I think should be done to end fistula. It's already being tried and being done. There's a lot of great effort now in Ethiopia to improve safe C-section, for example, access to C-section, access to obstetric emergency services. But here are the things that I think will really make or break any of those efforts. Number one, political stability is critical in building healthcare infrastructures and in ensuring access to safe maternal health. When you don't have political stability and there's conflict and hospitals are being destroyed, healthcare professionals are leaving because they're not being reimbursed properly for the care that they're providing, because a lot of the country resources are going to war efforts or other efforts. Any of those things can really affect your ability to make any progress in this area. And I have seen that in the last few years with what the conflict has done to healthcare infrastructures in different parts of the country. And what has that meant to maternal mortality, morbidity? We have literally gone back 20 years in some of these regions with our success in those areas. So I can't emphasize that enough. Leadership is a huge issue. We are, we're putting people in leadership positions, people with no leadership skills. We equate technical skills that doctors should be able to lead because they have a doctorate degree. Technical skills don't translate to leadership skills. We need to invest in actual leadership skills. We should not be putting residents who just graduated out of OBGYN residency training program as chairs of departments, which is happening in many institutions in Ethiopia. And we ask them to lead people who are 20 years their senior. How are they going to do that? We tell them to do that with no real additional resources or empowerment or training or mentorship. That is putting them, literally setting them for failure. I can't tell you how many turnovers I see with leadership. We start a project, we think things are going great, and then the person who's leading that effort steps down from their leadership because leadership is not a very rewarding place to be for too long. We need to make it a rewarding thing to be so that people stay in the leadership position and actually carry through projects to the end. If we have too many leadership turnovers, that's not going to work. And finally, gender inequality, especially in leadership. The gender gap index score for Ethiopia places Ethiopia 74 out of the 156 countries. So we're not doing very good with gender equity when it comes to leadership, to access to equal opportunities to different areas in the country. OBGYN field is a good example. Very few women go into OBGYN field, even though in the US, for example, 85% of OBGYNs are women. That's the reverse in Ethiopia. We need more women leaders. We need more women physicians who are leading the effort on gender equity when it comes to health outcomes, especially women's health outcomes. So we have a long way to go with that. We want girls to stay in school. We want women to decide when they want to get pregnant. We want them to have good access to family planning and be deciding when is a safe time for them to be pregnant. We want them to be empowered to say, I want to get health care right now and not have to rely on permissions from their spouses. So all of those things have to be dealt with in order for us to see the light at the end of the tunnel in terms of ending obstetric fistula. And with that, I will end my presentation just to be mindful of the time that we have here. And I look forward to answering your questions